An 18-year-old comes to the office after a traumatic injury to his face. Check out the full workup and treatment today on the open reduction. Welcome to the Open Reduction, your channel covering all topics oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we're talking about a bad facial injury. This patient is an 18-year-old male who plays college baseball. He was at practice when he was hit in the lower jaw with an errant pitch. He was immediately in a lot of pain and came to the office for treatment. He's barely able to open his lower jaw, and he feels like his bite is off. On physical exam, there is right lower facial ecchymosis, edema, and erythema. There is also an occlusal step between teeth 28 and 29. I am able to manipulate the proximal and distal portions of the mandible independently. Tooth number 2 has a fractured cusp, and number 29 is slightly mobile. It's immediately clear that this patient's mandible is broken, but I don't know the extent of the injury yet. The next step is to obtain a cone beam CT. There is a comminuted open fracture of the right mandibular body. The lingual plate is displaced medially, and the fracture extends to the inferior border of the mandible. Whenever I see an injury like this, it's important to check the contralateral condylar neck. The force of an injury like this can cause the jaw to fracture on the opposite side at its weakest point, which is the condylar neck. Thankfully, this patient's left mandible has no fractures. He's also lucky that the inferior alveolar nerve on the right is intact and he has no decreased sensation. Okay, so we have an 18-year-old male with a displaced, comminuted, open fracture of the right mandibular body. There are several treatment options, each with pros and cons. Doing nothing is not an option, given that his fracture is displaced and his bite is off. The next option is a closed reduction, where the teeth are wired together and the mandible is immobilized, allowing it to heal. There is also the option of an open reduction, where I would surgically expose and visualize these fracture segments, put them in the correct position, and then hold them in place with plates and screws. The main advantage of a closed reduction is avoiding a big surgery. I can sedate him in my office, place arch bars, and wire his jaw shut. The disadvantage of this is he will not be able to open his mouth for 4 weeks while the mandible heals. The advantage of an open reduction is he won't be wired shut for 4 weeks. But now we're talking about a surgery in the hospital under general anesthesia, and the surgery comes with potential risks. He is lucky he has no numbness in his lip and chin, but opening these fracture segments and manipulating them could cause a nerve injury. Also, it is difficult to reduce and plate a comminuted fracture like this. You're probably thinking, this channel is called the Open Reduction. Of course I'm going to open every fracture I see. Well, my mindset is not operate on everything. It's actually the opposite. Surgery is the last resort. If conservative measures have a high likelihood of success, then I like conservative measures. On this case, I chose closed reduction. I placed this patient in maxillomandibular fixation for 4 weeks. This is a healthy 18-year-old college athlete. His jaw is going to heal with immobilization. His parents and the patient were happy to avoid a big surgery. Here he is as I'm getting ready to take the arch bars off. His occlusion looks great, he has full range of motion of his mandible, and he has normal sensation of his lip and chin. I know a lot of surgeons would have opened this fracture, and that's fine, but for me, closed reduction was the best option. He had a great result and there were no complications. Thanks so much for watching. Please click those like and subscribe buttons and check out my channel for additional interesting OMFS cases like this one. I'm Dr. Tom Bolten. I'll catch you next time on the Open Reduction.